You welcome back. Mother and child health issues are germane and critical to the healthy living of any nation. To check how Nigeria is doing in this critical sector, we have in the house this morning the project director, Shopee MCH, meaning Child and Health, sorry, Maternal and Child Health, Dr. Okoli. Doctor, you're welcome on the program.
Thank you very much, and thanks for inviting me to your program.
It's a pleasure in time. Let's just look at this. You heard the Shopee MCH.
Yes.
Tell me the statistics before Shopee came on board. I mean, in the days of midwife services scheme that latched on
Shopee.
Yeah, Shopee.
Okay. First of all, I'd like to say that Shopee MCH and even the midwife service scheme is focusing on the rural areas of Nigeria. We've left the urban areas where we have the good hospitals and have the doctors and all that. But in the rural areas where the pain is, where the need is, we don't actually have the healthcare workers there. So what Shopee has achieved in the rural area is actually engaging midwives, community health extension workers and village, and posting them to those rural areas in the primary healthcare facilities where we don't actually have staff. So before Shopee actually came on board, we hardly have had any midwives in these 1,000 facilities, primary healthcare facilities, where the Shopee is across the country. The midwife service scheme is also in another 1,000 facilities. So across the two, there are 2,000 facilities. So to date, Shopee has posted almost 12,000 healthcare workers to these primary healthcare centers across Nigeria. And these are people that were unemployed before. So apart from contributing to reducing maternal mortality and all that, we are also creating jobs for the unemployed. So the Shopee program is actually engaging people that are unemployed, midwives that are unemployed, midwives that have just recently graduated, called basic midwives. They use the Shopee program to do their in-service training to get their license. And then also even the retired but able midwives, we are actually getting them to go to these rural areas. So far we have almost 12,000 of them across the country.
I understand these 1,000 facilities that you have across the nation actually belong to state government. That means there's a synergy, a collaboration between your scheme and state government. Tell me about it.
Exactly. There is nothing you can do from the federal level without actually engaging the states if you really want to do it properly. Because the facilities are owned by the states and the local government. The people that we are also trying to reach are also people from different states. So you have to engage with the states to ensure. So the state actually helped us pick these facilities in those rural areas. We gave them a criteria. We agreed a criteria where they must get facilities in the rural area, not in the urban areas. And then the facility must serve a particular number of population and also be in a particular local government that's where the needs are. So they actually helped us do that. We meet them quite often. Last year we had like 2 meetings, big meetings with the commissioners of health and the state primary healthcare development agencies from the states, basically to plan, to engage, to ensure that we are all in synergy in what we are doing. Even though the federal government actually picks the bill in terms of paying those midwives and paying those healthcare workers in the state. We have also set up what we call an MOU, Memorandum of Understanding with the states, to actually encourage them to also support these midwives that are working in the states as well. So through all these means, we actually engage the states to ensure that we're in synergy in what we're doing.
Thank you very much. I know the benchmark that you use to measure maternal mortality and child mortality is 1,000 per life path.
Yes.
How are we doing?
Yes. Okay. I would say that our goal, MDG goal, is to get to 250 maternal deaths per 1,000 life births, that 100,000 life births, as you've mentioned. The trend is going downwards, therefore maternal mortality is being reduced. It's just that it's not moving as fast as we would want it as a country. When we started measuring these things in 1990, it was actually 1,200 deaths per 100 live births. Then it came down to about 800 deaths per 100,000 live births in 2000. And then the last National Demographic Health Survey of the country, 2008, put it at 545 per 100,000 live births. We are awaiting the 2013 National Demographic Health Survey. But actually, the recent World Health statistics have actually put it at 560 per 100,000 live births. And also, the MDG office of this country have also done an independent review and put the latest figure at 350 per 100,000 live births. The essential thing here is that there is a difference, that it is actually going downwards.
And then when the scheme is making a difference.
And the scheme is making a difference. But let me even come to the scheme specifically, because we are not everywhere. We're in these 1,000 facilities across almost over 300 local governments. Since we started actually October 2012. We measured the baseline before then, and compared to the baseline, we have now seen a 40% increase in people attending antenatal care in these facilities where Shopee is. We have seen an increase in 55% of people coming to deliver in the facility, because that's one big problem we have. People might come for antenatal care, or the women might come for antenatal care and decide to go back and deliver with a traditional birth attendant at home, or deliver with their mother-in-law.
And that brings to this question. I understand you have an inducement scheme, as it were, to encourage people to come. Tell me about it.
One of the lessons we've learned actually delivering the midwife service scheme is that you just don't have what we call the supply side. What I call the supply side is supplying all these midwives, community health extension workers and all that. You also need a demand side. You need to create demand for the women to come and use the facility. So one of the incentives, the innovation the Shopee is actually doing is to what we call the conditional cash transfer. It's a little incentive, cash incentive support that we give to women to actually come and use the facilities. It is a pilot at the moment. We're in 9 states, including the Federal Capital Territory. We are scaling up to another 9 states this year because of the success of that. So far, we have...
Are you telling me that you have to give them something like a pocket money to access your facility?
Exactly. Because the women, you know, what is the problem? Why don't women use the facilities? There are several reasons. But the major one is actually education, money to actually buy the things for their babies when they are born, or even transport them to the facility, or even buy the card to register. So by the way, Shopee, all Shopee facilities, we're encouraging that even the drugs we supply and all that is free of charge, so at least to avoid these extra out-of-pocket expenditures. So when they come to the facilities in where we have the pilots, if they register, they have to fulfill a co-responsibilities as well. It's not just free cash, you know. So they register, we give them 1,000 naira for registering.
They don't pay for registering. You pay them for registering.
We pay them 1,000 naira.
Interesting.
Exactly. Then they attend another 3 antenatal care for 3 times, because the evidence base is that you have to attend 4 times. So that makes it, the registration and the 3 times makes it 4. We give them an extra 1,000 on top of that. Then they come back and deliver at the facility. We give an extra 2,000. And if they bring their child back for postnatal care, so for advice around breastfeeding, immunization of the child, advice around family planning, we give them another 1,000. So altogether, if you meet the whole continuum, 5,000 is what we give.
For accessing your facilities.
But we don't even stop at that. Wherever you've joined the continuum, we will pay you the pro rata. You know, we are not insisting that you must meet everything, because we are trying to encourage women to actually use the facilities. One of the things people will say to us is, are you now encouraging women to be delivering all the time? No, we have we have things that we have put in place.
And that's family planning.
As well as family planning, we have things that we have put in place. If you deliver in our facility and get all this in the pilot sites where we are, you don't come back into the program until after 2 years. 2 years, we prevent you to come into the program until after 2 years.
Yeah, I read a study somewhere that we have high mortality rate in the northeast and the northwest. Why?
That is very true. In this country, when you look at our maternal mortality by zone, the northeast and northwest zones actually come up higher. So actually, when we were setting up these facilities, we decided, based on this burden of maternal mortality, to pick out more facilities in the northeast and northwest zone. So for instance, in each state of those northeast and northwest zones, we have 32 facilities under Shopee. For the rest of the zones, we have 24 facilities. So in the northeast and northwest, we are also, apart from this incentive of demand services. It's also across the nation, not just Northeast and Northwest. What we are also trying to do is to ensure that we are doing a lot of advocacy, within the community to encourage people, because part of this is also education for the women to understand that they have to use the facility, they don't have to use the traditional better attendant. So we do a lot of advocacy. We work with the Ministry of Women Affairs as well to help us use their structure on the ground. We work with the state, we work with the NGOs to ensure that they are encouraging women to actually come and use the facilities. We also have this new cadre we call village health workers that I've mentioned. These people are not actually professionals, but we have gone to the villages and then asked what we call the ward development committees, the committees within those villages, to pick women that are 25 years and above, married or divorced, but of good standing within their community. 6 of them around each of the facilities where we are. And they actually go out of their way, go to the individual homes, encourage people to use the facilities. And it's good because it's the peer support and peer education with their friends. So even when they are going to the market with their fellow women, they are going to the farm, they know what to say. And they have done a lot for us in terms of actually creating demand in the facilities as well.
Okay. Now, have you considered this, that perhaps proximity to the facilities is an issue? Are you talking to state government to create more health facilities so that they can bring it nearer to the people, especially in the Northeast and Northwest?
Okay. What I would actually say is that the way we stand in Nigeria now, we have enough facilities, actually. And we have a facility almost in every ward, now. So it is actually, most of them are near the people. It's encouraging them to use the facility. One of the reasons why people are not using the facility is not when they come to the facility, they don't actually meet a healthcare worker, in the facility, because they are these facilities are in the rural area. So that's exactly why Shopee is actually posting these midwives to these remote areas. You won't believe where our midwives are, places where you would actually use a bike. You can't use a car to get to it. It will be a bike, or you use a boat to get to. We are everywhere where it's remote in this country. So we are providing those human resources that is needed for the women. At least when they come to the facility, they have somebody to look after them. We are also supplying drugs to those facilities, constantly supplying all maternal and child health care drugs. There is this UN Commission for Life-Saving Drugs, which the president, the commander-in-chief of the country, is actually a co-chair of the UN Commission for Life-Saving Drugs. We are supplying all those drugs that have been recommended by this UN Commission to all these facilities across the country. So it's not that when they visit the facility, they don't have the drugs, and they are asked to buy it. It is free of charge for those that are in our facility. We've also supplied them with equipment. We've also renovating the facilities, because the environment in which you are actually looking after the women has to be
very important.
Exactly, very important, especially for the healthcare workers as well, to stay put. So we are doing a lot of renovations, and the community is quite happy. These communities are quite happy. They call us all the time, and we take glory on behalf of the federal government to say, this is what the federal government is doing for you. Renovating your facility. Some will say, oh, we've never actually had these positive things happening to us before. And it's a good thing. It's a good thing.
Now, you are the project director of Shopee MCH.
Yes.
Now, where do you want to take this initiative to in the next 3 years or 5 years?
The Shopee is supposed to run till 2015. So what our immediate goal this year is to ensure that we continue as we are doing, but also try and scale up. So we're in 1,000 facilities now. Let us scale up to more facilities. Bring the state governments more into it. Because at the end of the day, the exit strategy is for the state governments to actually take this over and see that is a good thing. And then also ensure that if we have now done a building block for what we call social safety nets in this country. This conditional cash transfer is an example of it. Other Shopee programs are also doing like public works program, like the FEMA and all that, and then the youth and the women empowerment program. So hopefully the federal government might actually look at this and look at setting up probably a social safety net policy for the future. But what we are doing now is basically contributing to ensuring that the maternal mortality it continues to be reduced in the country.
Okay. Your emphasis, it seems to be more on maternal mortality or both, or child mortality. Are you taking both at par?
We are taking both at par, but everybody mentions maternal mortality because if it's important to keep the mother alive.
That's right.
For
the child to be alive.
For the child to be alive, but it's both actually. And even in that child mortality for the under 5, we actually also put more emphasis on the neonatal. Neonatal is death within the first 28 days.
Okay.
They actually contribute quite a significant percentage to the under 5 mortalities. And the good thing is that we have so many things that are evidence-based that can prevent this.
Okay.
And we know we can institute it, and that's what we are doing within this SureP program. For instance, the first 1 week, few days of a baby's life is very crucial. So there is a program called Helping Babies Breathe. We have ensured that all midwives and community health extension under this program are trained on that helping. But it's essential you keep that baby alive. If you can keep him alive or her alive within that first week of birth, it goes a long way, to ensuring that they survive the rest of their lives. Immunization is also crucial for under 5s. Nutrition is very important. So all those come into what we actually provide within those facilities. One other thing I want to actually add, apart from the cash incentive that we do, is that we also have other incentives in terms of what we call kits. There is something we call Mama Kit. We make sure that every pregnant woman that uses the SureP facility gets a Mama Kit. Within this Mama Kit, it contains all the things they need during the childbirth. So it's not a question of I'm going to ask my husband for money to buy this or buy that, or I don't have this for the baby or myself. It contains all the items they need, and it's free of charge. It's all in them, and that's what the federal government is providing for the women.
Yeah, and I know in this climb, the fact that people patronize unorthodox ways contributes a great deal to child mortality and maternal mortality. I mean, people give birth in churches and malls, even at home. They prefer the traditional way. The advocacy is focusing on that. People should realize, or you are training those people who they indulge in that to deploy healthy, hygienic.
Yeah. We actually, we don't personally want to encourage traditional birth attendants. So we know they exist. So what we do is, the village health workers I talked about that we recruit from the villages, we try to recruit them to be part of the village health care workers. So recognize that.
You try to recruit the traditional birth attendants in every community.
In those communities, we encourage the community to recruit them to be part of those village health care workers. So where we pay them, because the thing is, if you stop them, you're stopping their means of getting
livelihood.
Money. Exact livelihood. So they are part of these village health care workers in most areas. So we pay them the stipend, we pay the village health care workers, and encourage them and train them as we train the village health care workers as well. But the advocacy that we also do is encouraging people, like going to these churches, going to the mosque, talking to the villagers, talking to the WDCs, to encourage the women to use the facility. Because when you have set up everything, where you have renovated, you have the drugs, you have the healthcare workers, what is stopping them from using the facility? So it's about that education, to use them. Even the village healthcare workers, because like I said, they are not professionals. Some of them cannot read and write, but we still use them because they know the villagers themselves. We have what we call a pictorial guide. It's just by pictures, and they use it to educate these women, household practices. It's in Yoruba, it's in Igbo, it's in Hausa, and it's also in broken English, where they can actually go to these households and teach women the signs of complications of pregnancy, when they should go to the facility, when the cash transfer is due to them to go and collect. We use them to do all sorts of things, and they've been wonderful.
Talking about advocacy, are you partnering or you're working in tandem, or should I say in concert, with NGOs and civil society organizations who have flair for advocacy in this maternal mortality and child mortality area?
Quite recently, we engaged 6 big advocacy firms to go to each of the zones. And those advocacy firms have actually used their own network to do this same work that we are talking about here. Like I mentioned before, we are also working with the Federal Ministry of Women Affairs and Social Development. They did quite a big program here to educate their own state people, who will then go back and educate their own local government people. And they have this grassroots structure. We are working with the National Women Council for civil society, they have these structures on the ground as well to ensure that the advocacy is right.
Madam, it's nice having you on this program.
Thank you very much for inviting me. Thank you.
Yes, that has been the project director, Shopee Maternal and Child Health, Dr. Okoli.